Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health, and I'm back in the Sunflower House for a new edition of Speaking of Women's Health. October is National Menopause Month, and of course, all women, if they live long enough, go into menopause, and it doesn't have to be in October. So it's kind of a perennial topic that we have at Speaking of Women's Health. In fact, in our first season last year, I podcasted my entire updated book, The Cleveland Clinic Guide to Menopause. But in this special episode, I'm going to go over some of the most frequently asked questions. As some of you listeners may recall, we used to have an Ask the Nurse section on speakingofwomenshealth.com, our nonprofit website. And people could fill out a form with their health question. And one of our terrific nurses in the Cleveland Clinic Center for Specialized Women's Health would answer the question. And we still have all of these archived questions and answers live, and you can find them under our health tools section. So what we've done is gather some of these interesting questions that we've gotten from our website, from visitors, about their menopausal concerns, and we're going to share answers with you during this podcast. And there may be so many questions we might have to have part 2 of this podcast. Now, one of our wonderful retired nurses, Mary McDonald, for several years answered these questions, and she retired. And as you know, my beloved nurse, Lily McKinney, she retired, and she's been on this podcast a couple of times being interviewed in terms of planning for retirement and her retirement. And we have fabulous nurses. We have Nurse Alexandria De Los Santos Brown, and she has done columns on our website, speakingofwomenshealth.com, and has been involved in the podcast. And Nurse Rachel Ostermiller did a question and answer session with our executive producer, Lee, on preparing for bone infusion, since half of women in menopause will rapidly lose bone, and osteoporosis is a huge concern. So let's just dive right into the questions. This question I hear almost every single day. How will I know if I've officially entered into menopause, doctor? Well, unfortunately, there's just no such thing as a simple menopause test. Generally speaking, the classic diagnosis is if a woman is gone without having a period for more than 12 consecutive months. She's generally medically defined as menopausal, but there's other reasons people don't have periods. They could be pregnant. They could have had an endometrial ablation. They could have a progestin-only Mirena, Liletta, Kylena, Skyla, IUD. Or they could be anovulatory. And so you can't only go on the history. You need age, symptoms, and your physician or APP can confirm menopause, generally speaking, through the history and physical exam if you've had an accurate recording of your menstruation, including the number of missed menses, and if you have symptoms of hormone deficiency, such as classic hot flashes, vaginal dryness. We may want to do a bone density test because half of women rapidly lose bone at the time of menopause. Now, I frequently will get an FSH, a follicle stimulating hormone, as well as an estradiol level. And if you're over age 50 and you've had 12 months of no period and classic blood work consistent with menopause, generally speaking, there's no more eggs. However, I have to say it's a challenging diagnosis sometimes because I've seen women, particularly women who've been on hormonal contraceptives, that have suppressed ovulation, even though most eggs are lost through atresia, not through ovulation, of which most women on average would have about 400 ovulations in their lifetime. And there's millions of eggs that a female is born with. However, I have seen women with classic symptoms of menopause, signs of estrogen deficiency on exam, like a thin vagina, who then are given hormone therapy and then they start bleeding again. And when you recheck the hormones, the FSH is normal and the estradiol is higher than you'd expect for what estrogen you're giving her. So it's very important to be able to diagnose the age of menopause. Certainly, somebody by age 60 is in menopause, that is for sure. But um, a lot of women I find don't really pay attention or have the whole historical details about their period, especially if they don't have symptoms and they weren't worried about pregnancy, if they have had a tubal ligation or they're not sexually active with someone who could impregnate them, or maybe their partner has a vasectomy, or maybe they've had a lifetime reproductive history of infertility. So that's really why all women, regardless of reproductive status or interest, should pay attention to their periods. And menopause shouldn't be a time of mourning. I just saw a lady in the office the other day who was 48 and had had both her children and clearly was in menopause. And she said she felt really bad about it. And it's it's a new phase in life. And the truth is, a lot of the medical issues associated with midlife can be managed. And eating well and exercising, protecting the skin from sun damage, taking the right vitamins and supplements, particularly vitamin D3 and K2 if you live in a northern climate, staying active, using your brain, and developing a personalized approach to your second half of your adulthood is very important. Many women feel very comfortable in their skin during midlife and beyond. They have wisdom and confidence and experience. They're happy not to be plagued with painful or heavy periods or worry about pregnancy, or the up and down cycles of PMS go away. So if you haven't already adopted a healthy lifestyle, certainly now is the time. The next question: what's the difference between premenopause, perimenopause, menopause, and postmenopause? How am I going to know when I'm there? And it's not exactly a destination, it's just kind of a continuing road trip. And some of the confusion about menopause is just purely semantical. When a woman starts to have fluctuating hormones that may or may not be associated with symptoms, may or may not be associated with changes in menstrual cycle, it usually occurs in the 40s or 1 to 7 years before the final period. And the transition period in some women can last longer than 11 years. And with prolonged perimenopause, there is an increased risk of symptoms and other problems. And if your ovarian function, the ovaries, the function of your ovaries is erratic, that can be associated with some of the signs of hot flashes, night sweats, skin itching, trouble sleeping, brain fog, irregular periods, skin crawling sensation even. But once you finally run out of eggs, it's official, ladies, that's menopause. And in the United States is about 51.3 years, but it's a wide range, 40 to 60. So find out the history of biological females in your family, like your mother or older sister. And I've seen women who've had an ovary out who still don't reach menopause till 55. I have seen women have regular cycles well into their late 50s. So it's very individual. Question number 3. What can I do about this facial hair I've developed as a result of menopause? That's a very distressing symptom. Many women do not experience excessive facial growth. Some of it is familial, and it can also be hormonal. If you lose your estrogen, but most women still make their testosterone, it's a change in the balance. And there is a more masculine ratio, so to speak. So if you're genetically predisposed to hair on the chin, the upper lip, or hair thinning, and our hair thinning podcasts certainly are so popular, then that can occur. But if you take estrogen, particularly oral estrogen, that seems to help quite a bit with this happening. And there's waxing, depilatories, liquids, topical creams like prescription Vanica. And of course, there's laser hair removal. And if you have a color contrast between the color of your hair and your skin, the laser works a lot better. So that's important to know. And also, generally speaking, insurance doesn't cover it. It's considered cosmetic. Can menopause cause a woman's voice to change? Well, luckily, for the majority of us, we don't experience any noticeable voice change during menopause. In fact, one of my listeners said, during this podcast, it sounds like your voice is getting younger. I don't know if it's sometimes the audio, but rarely women might lose just the upper register of their voice. And this is important if you make your living singing, you're an opera singer, or professionally, you have to keep your voice just a perfect tone and pitch. So if that's the case, I would recommend any professional singers visit a menopause expert long before they reach menopause. Now that I've become menopause, the next question is, do I still have to be concerned about birth control? Well, yes, until we know for sure you're in menopause and you've gone a whole year without a period and we've confirmed that you're not fertile anymore. So using safer sex techniques like latex condoms if you're not allergic, using barrier methods, which also can help reduce the risk of sexually transmitted infections. Women who need contraception, who have a normal blood pressure, who do not smoke cigarettes, because you cannot be on hormonal contraception with estrogen and progestin if you're over 35 and smoke even one cigarette a week or a month because of the increased risk of blood clot. If you're otherwise healthy, many times we just skip perimenopause and have women take hormonal contraception, whether they need it for contraception or not. And many women still do, even if they think they've completed their family and or they've had some periods of infertility in their history, because it treats perimenopause as well. And then you get to pick the time that you make the transition from hormonal contraception to hormonal therapy. And generally speaking, that shouldn't be right before your daughter's wedding or right before a big anniversary trip or a big presentation at work. And it doesn't have to be artificially at age 50 or 51. Certainly, if you're 52 and you already have a completely permanent, reliable form of contraception, then 50% of women are in menopause, and we usually pick a time to transition. If you need contraception, then we push it out to 55, sometimes 56, 57, just depending on the woman's history and her desire to use other forms of contraception. One helpful trick, though, for women who want to know for sure when they go into menopause and they want to reduce their risk of clots, which are much greater with pharmacologic synthetic hormonal contraception than with menopausal hormones, is we can switch you to a progestin only form of contraception like norethindrone acetate, commonly known as Arin or Micronor, or Slind, which is drospirenone, which is a progestin only contraception that does inhibit ovulation and is good on skin and hair and blocks testosterone effects on the skin and hair. And that doesn't suppress the FSH. And we can measure the FSH and estradiol. And if you're having hot flashes or night sweats or signs of low estrogen because of your own ovaries fluctuating estrogen levels, we can add like an estrogen patch. And then we can see the rise in FSH. And there's one hormonal contraceptive, Natassia, that's FDA approved to treat abnormal uterine bleeding in perimenopausal women after it's been evaluated. And that has natural estradiol and doesn't suppress the FSH. And Nextstellis, which is another natural estrogen E4 estetrol contraception with drospirenone, we also can measure the FSH. And if you have a Mirena or a progesterone IUD, levonorgestrel IUD, and whether or not you have periods or not, certainly once you don't have periods, if you're over 40 or 45, even if you feel great, you should still ask your healthcare clinician to check your FSH and estradiol to date when you go into menopause. Now, the levonorgestrel IUDs are now approved for up to 8 years for contraception, but I generally only go 5 years if I'm using it for uterine protection and I'm adding estrogen. So the next question is, my hot flashes aren't as intense as the ones my friends describe. They're actually warm rather than hot. Is that normal? Well, while hot flashes are extremely common in perimenopause, not all women experience them at the same intensity. They might be mild, like a light blush, or they can wake you up from a sleep. They don't usually last more than 30 seconds to no more than 5 minutes, and they usually disappear within a few years after the transition of menopause, but there are some women who flash their whole life. It kind of depends on how you're wired in your hypothalamus in the temperature sensation area and how your candy neurons in the brain respond to fluctuating or absent levels of estrogen. Question 7. I'm perimenopausal and I've been told I should just only take low-dose birth control pills. Is that true? Well, compared to regular birth control pills, the lower dose of estrogen in the low-dose pills may certainly be safer. While regular standard hormonal contraceptive pills or patches or vaginal rings contain about 30 to 35 and rarely 50 micrograms of ethinylestradiol, these low doses usually contain just 20 mics, which is generally enough. And low estrogen only contains 10 mics. And as I mentioned, we have 2 hormonal contraceptives that have natural estrogen, either estradiol in Natassia or estetrol in Nextstellis. They generally regulate the menses and do provide protection and reduce the risk of ovarian cancer by preventing ovulation and uterine cancer by giving enough progestins. And they generally prevent bone loss in most women. But women with a history of active breast cancer, active heart disease, blood clots, smoking, uncontrolled hypertension, metabolic syndrome with high triglycerides and high blood pressure and high blood sugar generally should not take these pills in perimenopause because we have other options. And of course, anyone with any cardiac risk, since that is the number one cause of death in women, should get assessment. You have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and we are in this question and answer session on all things menopause, and we're about halfway done the questions. The next question, 8, is how are hot flashes treated? Well, we certainly have had FDA-approved hormone therapy for decades. We've used estrogen for over 7 decades. And we have lots of non-hormonal options. Most are what's called off-label, but the first non-hormonal option was paroxetine, brand name Brisdel 7.5, similar to Paxil, which is used for anxiety and depression, but at a lower dose. And in 2023, long awaited, we finally got the first candy neuron inhibitor, fezolinetant, which is sold as the brand name Veoza, 45 milligrams daily. We also have over-the-counter and prescription therapies. We use off-label anticonvulsants like Neurontin. We can even use overactive bladder medicines like Ditropan, oxybutynin. Some blood pressure medicines like clonidine can block some hot flashes. We frequently will use off-label NSRIs like Effexor venlafaxine, or the active ingredient of Effexor is desvenlafaxine, brand name Prestique. Changing diet, losing weight, dressing in layers, B-complex vitamins, vitamin E, which slightly thins the blood. E is an Earl. Many times can slightly block hot flashes. And I frequently recommend vitamin E in women with a history of any venous blood clots. Now, a lot of women ask me about soy or soy products, and most humans don't have the enzyme to convert the soy isoflavones into equal, which is a weak estrogen. Cynomolgus monkeys do, and that's where a lot of the research has been done. But if you want to try to add soy in place of other foods for calcium, for cholesterol, it's worth a try. But if you're having estrogen deficient symptoms, you've got to ask what the status of your bone is in the genitourinary system, because these non-hormonal options that treat hot flashes don't help your bone or vagina. Question 9. How can I cope with the emotional changes that occur during menopause? I see many women who come to me because of emotional symptoms that they assume are their hormones that are actually their neurotransmitters. And certainly, if you're having hormonal upheaval and lack of estrogen, then mood medications don't work as well. People don't sleep as well, which gives them less reserve. So it's very important to tease out the timing, what your other comorbidity symptoms are. If you've never had any emotional symptoms and boom, you stop your period, have hot flashes, and feel like you're going to cry at the drop of a hat, chances are hormones will indeed help you, as well as the physical symptoms of hormone deficiency. So, the classic symptoms of hot flashes, which can lead to sleep problems and fatigue and brain fog. Some women just complain of being irritable or being more sad, rarely aggressiveness. Anxiety can happen when you lose estrogen and progesterone, because then you have surges of stress hormones from the adrenal gland, like adrenaline. And some women who never felt anxious before feel a lot more anxious, and many times like natural progesterone, which is a natural anxiolytic. Now, others describe trouble concentrating, lack of motivation, worsening of any ADD. Sadness and irritability tend to be more common emotional symptoms. But irritability can be caused from lots of other conditions, and sleep disorders many times are common at midlife. Meanwhile, lifestyle changes can help you manage the emotional changes of menopause. So, our usual advice about healthy eating, regular exercise, good sleep, self calming strategies such as yoga, meditation, rhythmic breathing, avoiding recreational drugs, alcohol, tranquilizers, I think is very important. Finding creative outlets to foster senses of achievement, staying connected to your family, your community, nurturing friendships. A lot of times, menopause occurs around the time that people notice empty nest. And this is a time to kind of rediscover hobbies and interest, maybe community volunteering, spending more time with friends, or just learning something new or reinventing yourself. Now, menopause in and of itself does not cause depression. Actually, depression is more common in women in their 30s with young children. But some women can develop depression during menopause. So if you're not able to cope, talk to your primary care physician. You may need to see a mental health specialist for extra support. Question 10. Well, I'm officially in menopause and I'm gaining weight. What can I do to get rid of this belly weight? Okay, that is the most question that I get and the most common complaint of women. Even though weight gain is not a classic menopausal symptom, menopause is associated with being older, generally speaking, not always, but with each successive decade, the metabolism slows down. And lack of estrogen can cause those adrenal surges, which increase cortisol, which do tend to pack calories around the waist. And women that don't feel good because of hot flashes and mood swings and generally just not feeling like they previously did sometimes turn to food and alcohol to treat their symptoms, which is not what you should do. And the older you are, regardless of menopausal or hormonal status, the harder it is to rebound. And there is no miracle menopause diet. I do think with time and more research and investigation into pharmacogenomics, we're going to find that some diets are probably better for some people based on their genetics and metabolism. We generally favor intermittent fasting because it drops insulin levels and it's anti-aging. We also recommend reducing intake to about 80% using smaller plates. And then in 30 minutes, if you're still hungry, you can go back and get food. Following a higher protein, higher heart healthy fat diet, minimizing sugar and sweets and simple carbs, breads, pastas, many times help drop the insulin levels. And some people have called it natural Ozempic to go on a more keto type diet. But if you're going to do anything that might put you into ketosis or any fad diets, really, you should see an expert and be monitored, because we do generally like to include fruits and vegetables for minerals and potassium. And people who go on really strict modified protein sparing fast usually do need to be supplemented with minerals and electrolytes. So, in general, you should be aware of what's going on with your body and kind of weigh in once a week or at least once a month. You should plan to do more exercise and eat less with each successive decade. It doesn't take much extra food to gain weight. An extra carrot stick a day, and that's 20 pounds at the end of a year. I was amazed during pregnancy, you only needed an extra 300 calories, which was like a big apple is all extra I ate with my first pregnancy. And you can gain 25 to 30 pounds pretty easily in 6 months. Now, granted, in pregnancy, some of that is fluid weight, but some of it is definitely body fat, and it's building another human being. So, exercise is best for maintaining weight, but exercise alone is not going to do the trick. It's very important to ingest the essential amino acids, and there's two fats, omega-3 and omega-6. Most of us get enough omega-6s, but a lot of people don't get enough omega-3, which also helps the mood. Portion control and reading labels is so important. Fiber helps fill you up. Journaling what you eat can keep some people accountable. And you do have to start weightlifting gradually progressive. You may need supervision or the help with physical therapist or an exercise coach, because you want to keep your lean muscle that many women lose. And some women that have surgical menopause with their ovaries out do become testosterone deficient. And testosterone is very important in muscle metabolism. Limiting caffeine, which can be an appetite stimulant, although some caffeine can be helpful for reducing fatty liver, which is endemic because we're having so much metabolic syndrome problems with weight gain around the belly and high blood sugar levels and insulin resistance and hypertension. Some women don't have hot flashes, but metabolically, they just gain weight. Their blood pressure goes up, their cholesterol gets worse, their eating habits get worse, and it's really a vicious cycle. Alcohol needs to be limited. That's so full of calories, does increase breast cancer risk. Some people will do dry Januaries. I frequently will give up alcohol during Lent, or as much as possible if I'm finding that my clothes are a little bit too snug. And caffeine, alcohol, sugar especially, and salt, that quartet sometimes will sabotage your weight plans unless you sabotage them first. Question 11. I'm a little bit confused as to why people generally say that eating soy isn't good for you, because it's full of estrogen, right? Isn't that good? Well, the answer is soy foods are not full of synthetic estrogen. They're composed of isoflavones and soy protein. And if you prefer soy milk over dairy milk, or soy burgers over hamburgers, or soy nuts over peanuts, it's fine to substitute them. And for some people, it can really help cholesterol ratios. I don't recommend soy supplements or pills or powders, because in very high doses, they can stimulate the estrogen receptors in the uterus. And if you're low in estrogen, generally speaking, replacing estrogen is what is needed. Just like if you're low in thyroid, you're not going to just go eat a bunch of extra iodized salt. Okay. You need iodine and you do need some salt, but that's not going to be the treatment for iodine deficiency. And if God forbid you have type 1 diabetes, you have to take insulin shots, or get a new pancreas through organ transplant. And we don't go around doing ovary transplants. And unfortunately, the woman's body is designed to stop menstruating, which is certainly welcome, as well as it's past the time for childbearing in the second half of your life. However, when you don't have any estrogen, that is a problem. And our people expect to live vibrant, longer lifespans than they just did even 100 years ago. And several hundred years ago, it was not unusual for women to die in childbearing, or just to die by your 20s or 30s or 40s. It was pretty unusual to live into your 70s, 80s, and 90s. And my patients all expect to and want to live to that age. Question 12. Oh, this is such a common question. If I take hormone therapy for my menopausal symptoms, will I stop gaining weight? Well, there's no guarantees, but hormone therapy interacts with lots of other hormones in your body, helps regulate your metabolism. But organic causes of weight gain, such as diabetes, untreated sleep apnea, side effects from other medicines that can affect hunger, thyroid disease. You may want to see your family physician for a complete physical and talk about potential referrals if your BMI is over 27 and you've got associated medical problems, or even if you don't have medical problems, but your BMI is over 30, and that's not because you're ripped with muscle, like my sons who have BMIs of 30, but they don't have excess body fat. And there are tests that can be done to check body composition. Generally, anyone with a BMI over 40 is in serious problems and usually needs to see a bariatric specialist. Question 13. What is the difference between using an estradiol 0.5 patch versus taking an estradiol 0.5 tablet? Well, they're both well studied and they've both been used, and they are options. I think oral estrogen is generally better for someone who's already been on hormones or been pregnant or had a baby or a C-section, and we're not worried about blood clots. Oral estrogen tends to be better for women who have higher testosterone levels and are bothered by androgenic male pattern, female pattern hair thinning, or acne, or chin whiskers. Sometimes women with mood problems feel a little perkier on the oral. However, the patch is generally preferred if someone has high triglycerides or diabetes, or in anyone with a prior history of blood clot, or in anyone taking a blood thinner. The patch can be more helpful if people don't like to swallow pills or have gallstones or want to avoid effects directly on the liver. Rarely people can have allergic reactions to the patch, but most women are able to tolerate it. Estrogen also comes in sprays, Eva Mist, gels that can be rubbed on the skin. Generally speaking, the patches give better estrogen levels than the sprays or the gels. And the oral estradiol has to be given twice a day because there's a very short half-life. Now, if you take oral estradiol with a progesterone, like natural progesterone in Bijuva, or norethindrone acetate in Activella or Mimvi, or estradiol with drospirenone in Angelique, then if it's combined, it lasts the whole 24 hours. Now, oral Premarin, which has 10 different estrogens, that lasts for 24 hours. So there are nuances for most women under 65 who are healthy. A lot of times it just comes down to a woman's lifestyle as well as what her insurance covers, sadly. Although you shouldn't have to be limited to just what your formulary says that you can be on. I have some women whose formulary only includes birth control pills and they don't need birth control hormones. It's really pretty insulting. So, if you haven't listened to the podcast on how to save money on medicine, or you want to go on our speakingofwomenshealth.com website and put the word money in and read the great column by my fabulous nurses that has all sorts of links and tips about how to save money on medicine, do it right away. It's so important. And even if you don't have an issue with affording your medications, chances are somebody in your circle or elderly relatives or a neighbor or a coworker. And I really think that the more people understand about the formularies and the pharmacy benefit managers, and the fact that going through your insurance is not always cheaper, it's very helpful. Okay, we are winding down on this podcast. But like I said, if there's a lot of questions, and you can enter questions on our Contact Us form on our website, speakingofwomenshealth.com. So the last question, can you provide me with some simple remedies for night sweats? I get them off and on. It's worse when I'm worried or stressed. And sometimes I even feel like I'm having a mini panic attack. I can cool down pretty quickly in the day, but at night they're so annoying. Well, here are some tips. Obviously, identify and avoid your hot flash triggers, but you can't avoid nighttime and the need to sleep. During the day, the most common hot flash triggers are stress, caffeine, alcohol, spicy foods, and tight clothing, synthetic fibers on the skin, heat, cigarette smoke. So at night, keep your bedroom about 65 degrees. You might want a fan during the night or day. You want to wear cotton, light, fibered, natural clothes. Deep breathing can be helpful, paced breathing during the day, exercising, and staying healthy and maintaining a normal body mass index. But if these symptoms are affecting your sleep, you really should go on hormone therapy if you don't have contraindications. And if you do, or you just simply don't want hormone therapy, I would talk to your physician about Veoza. It's a very effective non-hormonal therapy to treat your vasomotor symptoms. You do need your liver function checked at baseline and every 3 months for 9 months. So you'd have to plan for that. If you start on hormone therapy, you should plan to see your healthcare clinician in person or virtually in about 3 months. And there can be some bleeding or spotting if you have a uterus in the first 3 to 6 months. So you have to work out a plan on having to deal with that. We can use off-label medicines, as I mentioned earlier, like NSRIs or anticonvulsants. But again, those will not help your skin or hair or your bone or your vagina, which also can be impacted by dropping or fluctuating hormone levels. Oh, I guess actually another question just slipped in. Question 15. I am wondering if bioidentical hormone therapy, BHT, is right for me. I'm not experiencing any ill effects. I'm 52 years old and I haven't had a period for 14 months. But I kind of do have some hot flashes and night sweats. And other than that, though, it's pretty rare and I really feel good. Well, that's terrific. It's wonderful to feel wonderful. But just because you don't have a period and you're over the average age of 51, 52 in menopause doesn't mean that you're completely in menopause. You could still have a decent estrogen level, and maybe that's why you feel good. You might not be making progesterone, and that estrogen could be building up in the lining of the uterus. So see your physician, ask for an FSH level and an estradiol level. If you're due for a pelvic exam, get a vaginal exam by a women's health person who can look for signs of hormone deficiency and signs of genitourinary syndrome and menopause. If you are indeed in menopause with no symptoms, we'd recommend a baseline bone density within 2 years to see if you're rapidly losing bone, because this could affect your decision to take hormone therapy. If you don't have a family history or risk factors for osteoporosis, you could wait till age 65, but 52 to 65 is 13 years, and women can lose a significant amount of bone in the first 5 years of menopause. So I personally wouldn't want to do that. And just because you don't flash doesn't mean you're not going to lose bone or have changes in the vagina or have changes in your sense of well-being or your executive cognitive brain function or your sleep or your metabolism, cholesterol, blood pressure. So you certainly want to get a cardiovascular risk assessment, a cancer risk assessment. And you could be one of those lucky postmenopausal women who don't have any problems. And I occasionally see them, mainly in some friends, because people who don't have symptoms don't usually come to see me. Although some of those women do need treatment for the bone. And most women, as the adrenal gland function reduces just with age, do need some local treatment to the vagina and bladder. But there are some lucky women who have good ovarian stroma, good adrenal function, good metabolism, good genetics, great lifestyle, who do seem to be spared. And that's wonderful. Just like there's women who could have a baby in the field and then pick the baby up, nurse the baby, and then go right back to work. Okay. But that's not the usual situation. And even natural events need some sort of assessment and guidance and oversight. If you truly are hormonally deficient, you had early menopause, or your ovaries were taken out, or you had chemotherapy, or you have a family history of very early menopause, you clearly have a lower estrogen level than a man older than you, then you shouldn't feel bad about that you need help. You should just be glad that it's 2024 and not 1800, where all they had was, injecting animal gonads, or other crude therapies. So it's great to do things naturally and with lifestyle, but that's not always possible. And the women who do end up on hormones do reduce several long-term disease risk, and they do tend to live longer. So for women that are really suffering and frustrated, they wanted to do it naturally, and they are in my office, I say, well, the silver lining of seeing a menopause specialist and getting on hormones is you do tend to live longer and have less burden of disease. So I think it's always important to look on the bright side. It's wonderful if you don't have these problems and burdens. But if you do, you should get assessment and treatment and get the most information before you see your healthcare professional. And accessing our social media, our free treatment guidebooks, this podcast, which you're listening to, reading about all of this on our website is so important. And I really want to thank you all for joining me on this podcast of Speaking of Women's Health. And again, if you've got a question, go to speakingofwomenshealth.com and complete the contact us form in the About link. And you can hear your question answered on a future podcast, hopefully. And if you don't already subscribe to a podcast app on your computer or phone or iPad, you can find us on Apple Podcasts, Spotify, TuneIn, anywhere you listen to podcasts. And you can also watch our podcast on the Rumble channel or listen on the YouTube channel, all called Speaking of Women's Health. Please feel free to share this podcast and give us a 5-star rating. And I'll look forward to seeing you back in the Sunflower House again.